So thank you, Patricia. I think at this time would like to invite Roger and David up. Just to reiterate what was mentioned, I think make sure you use a microphone. It would be good if you direct your question to one of the panelists specifically, or if it's a lightning round up for grabs question, you can direct it to the panel. So we'll give people a minute to assemble at the microphone, and all right, so we have, and if you want to say your name and where you're from, that would be great.
So I'm Karen Sherman. I'm from Kaiser, Washington, and I have a question for David Elton. I loved your presentation, but as I've been thinking about who gets opioids, and I'm a clinical trialist, I would, of course, love to see a randomized controlled trial, and of course, you don't have those data. How have you thought a bit about who shows up to a chiropractor at the first visit versus who shows up to the emergency room, and how their presentation might influence what they get? And have you figured out some ways to sort of disassociate some of that confounding?
We haven't figured it out. Anybody here figured that out yet? No, that's a really important consideration. It's self-selection, and when we more get into the first provider scene data, which we'll unpack a little bit more tomorrow, that's the first response is, well, these patients are different, self-selection. True, although that doesn't eliminate the need for the provider that's the recipient of the patient to follow the guidelines that Roger has put out, indicating that, opiates aren't indicated for the vast majority of back pain. These other therapies are. And so patient self-selection and preference is important. But it's almost inexcusable when we see the rate of opiate prescribing for routine back pain and the lack of use of manipulative therapy, acupuncture, active therapies. So our focus is more on how do we work with our provider community to translate all that we know into practice so the likelihood of receiving the evidence-based therapies goes up and the exposure to the opiates goes down. So it's a complicated question. The answers are not simple, but the patient preference, and you apply it to imaging, right? They come in with imaging. Well, I want a picture of my back. Well, the guidelines suggest that's not indicated. Here's why that's not indicated, and that's hard to unpack in 7 minutes if you're a primary care doc and you need to work through all that. It's a complicated question, important one. We don't have all the answers, but doing a fair amount of work with providers to help.
Thank you so much.
Thank you. We'll go to the middle.
David Atkins from the VA. This is for Patricia. So if I understood your presentation, the first part of your presentation were looking at cost-effectiveness studies without actual data based on sort of assumptions of effectiveness. So you had a long list of sort of published cost-effectiveness studies, and I wasn't sure whether they were modeling studies that assumed a certain level of effectiveness or actually model what you did in the second half, which was actually using people's data from their trials.
The first part were the actual published trials. So those were mostly randomized controlled trials that were done that had economic evaluation wraparounds.
Okay.
Or you will have noticed there was one from the VA that Stephanie Taylor and myself did there, right, showing those cost savings. And so, no, those were if you're talking about cost effectiveness in a specific setting, those are the best studies. The models basically help us just fill in the gaps and see where to target for future research.
Okay. So my other question was, in the ICER review, it looked like CBT was, provided benefit but not cost effective. In your presentations at the end, CBT looked like it was cost saving. And do you have thoughts on what was going on there?
Yes. Dan Shurkin was asked by JAMA Internal Medicine to write a little commentary about that, and he invited me to join him in that. And one of the things we point out in there is that the ICER group did use the cost of individual cognitive behavioral therapy in their results, and so they're way, from our opinion, they're way too high, the cost that's shown there. They also use the cost of yoga, one-on-one yoga, whereas, again, the results of the effectiveness studies were group studies in both those cases, but the costs that were applied were for individual. So catch me later. I can give you all the details of that study if you want, but I wanted to talk about it.
Like the best, in that study, what were they assuming the cost of yoga were?
$76 a treatment. No, that was yoga. Yeah.
Right.
I'm pretty sure that number's right, but anyway.
Thank you. We're going to move on over to the left.
I'm Eric Skumaker, and I'm with the Department of Defense. I work with the Defense and Veterans Center for Integrated Pain Management. I have two quick things. One is specifically to you, David, and the other is a free-for-all grab. I want to make sure I understand real quickly. The first slide you put up there across your beneficiaries is the cumulative codable problems associated with pain. Is that correct? All of those categories of care were pain related. So you had the highest ones were cardiovascular disease and infectious disease, but were they all pain related to those diagnoses?
No, those are just general
All your
roll-up of all cardiovascular conditions, for example, so not specific to pain.
Not specific to pain. Okay, that tracks better than with the experience, because musculoskeletal pain is probably the most, musculoskeletal problems are most associated in our populations with pain. So then the toss-up is this, and I guess it anticipates tomorrow as much as anything else. Everything that was said today was in some ways, especially the work that Roger showed, has been known for a long, long time. I mean, 8 years ago, we in the DoD published a very similar kind of task force report that said that we've got pretty good evidence right now for the use of all of these modalities, especially yoga and Tai Chi. And in truth and wending, I'm married to a yoga therapist. I'm not trying to advocate for yoga, but and the usual treatments for these are highly invasive, are highly destructive. I mean, candidly, orthopedic surgeons say that as many as 30 to 40, and the real honest ones say as many as 80% of people who go through spinal fusions do not get better and actually get worse. So why 8 to 10 years later are we still debating about whether we should pay for these things? I don't understand. I'm really confused about that, and I guess that's somewhat something to come up again tomorrow. But if you have any comment about that right now, I'd really like to know that. United Healthcare is the DoD care plan in the West. So as many as 3 million of your patients are our patients. I'm just wondering, what is it going to take to kind of cross the threshold?
Well, we will unpack that a little bit tomorrow. So even in environments where we have full coverage, you're far more likely to receive therapies that are not recommended by the guidelines. You're far less likely to receive therapies that are. The determinant on that is your front door you walk through. So who's literally the first provider I see for this condition sets your trajectory for the next 6 months, 1 year, 2 years. And your likelihood of receiving the recommended therapies is based on that decision on who's the first provider I'm going to go see.
But David, I think, if I might say, I loved your last slide. Coverage is not translated to use, because we know in the DoD population, everybody is going to use these things, but has to pay out of pocket, and so they're not coded anywhere.
So more to come on this. Did you want to say something, Roger, tomorrow? Or now, before tomorrow?
Sure. I'm a primary care doc, so I think until it's as easy to do these things as it is to order an imaging test or to prescribe an opioid, then people are going to do what's easiest. And so we have to make it easier for people to refer. And I know all the evidence, and I want to refer people to this stuff, but it's very hard for me to find a psychologist that I know that's going to provide the right treatment that takes the patient's insurance that's available and all these other things. Or an acupuncturist, if somebody asks me who should I go to see for acupuncture, it's very hard for me to give them advice on that because I don't know there's no kind of system to vet these providers. The paperwork still, even though I showed you in Oregon, they're trying to make these treatments more available, at least for the Medicaid population, it still requires me to write a letter or do something extra. And these are all I think they're going to continue to be barriers. I do think there's been progress. I mean, this is, again, I started working on this stuff, 10 or 11 years ago, and the perceptions and beliefs about effectiveness of non-pharmacological treatments, I think, have changed over that time period, where it's kind of accepted now that these treatments do work and that we should be using them more, which was not necessarily the case 10 years ago. So I think it does take time, but we need to be creative about how to address these things.
Thank you. We'll go to the middle.
This is Dan Carr, Tufts University. Thank you very much for these great presentations. I have a question and then a couple of comments. In Dr. Elton's data, there was one line that said injections and the next line said anesthesia. And I'm just curious, was that anesthesia billed for an intraoperative anesthetic while surgery was being done? Or
Yes.
did it? Oh, okay.
Yep.
So that leads to the comment. Here and there, we've seen reference to more invasive therapies like spinal cord stimulators, for instance. And I think it's important to keep that on the purview of what this group will be thinking about, because it's almost like the area of neuromodulation is a parallel universe. We know it's out there. We don't try to deal with it, but a lot of it is provided at great cost. So I would say early on, please keep the conventional interventionalist approaches underway. The other related comment is just that we've seen now a great deal of flexibility and broadening of what is meant by evidence and how to use evidence. We've seen editorials in New England Journal by Dr. Frieden, and last week there was another editorial talking about going beyond randomized controlled trials. This thought is going to come up again and again and again, that this is a good opportunity to reflect historically that if you look at Archie Cochrane's writings, the methodology he developed was designed to treat and allocate resources to populations in post-World War II Britain. And it was therefore designed to minimize the effect of outliers and to assist them in the estimates of resources. We've seemed to lose track of that. Most pain clinics see nothing but outliers. And we're trying to use a methodology that's population-based at a time when we're hearing about precision medicine and personalized medicine. This would be a good time to get that clash or collision on the table. Thank you.
Anyone on the panel want to respond, or are we ready to move? Okay. We'll go back over to the left side. Yeah.
Monica Gross with the POISE Project and Alexander Technique for Pain Management Initiative from North Carolina. I had a question for Roger just on that 2017 follow-up that you did on guidelines. And you mentioned that exercise had durability at a year, people who had exercise intervention. Were they, from those gains, were they adhering to their exercise program? Was that checked for? Or had they just had that intervention and they were no longer adhering to their program? Thank you.
Yeah, that's a great question. Most of the trials, it was not clear what they were doing. So in most of the studies, what people get is they get like an 8 or 12-week course of exercise, 1 or 2 sessions a week or whatever their regimen is. They are typically trained to do home exercises, but then there's no formal supervision after that 8 to 12 weeks, and we don't know exactly what they're doing at 1 year. Presumably some people are still doing it and others aren't, but on average there do seem to be some persistent effects. There is also some data suggesting in people who have frequent recurrences that doing an exercise program can prevent future recurrences. So, that's what we have.
Yeah, it was if you collected the data of who was adhering and who wasn't, because that would seem to be a very important factor with exercise, whereas other approaches like meditation or mindfulness-based approaches might not need that adherence to the protocol.
Yeah. Like I said, most of the trials just didn't report that information.
Thank you.
Thank you.
Hi there, Dr. Robert Bonactar, Scripps Clinic. I'm a primary care physician, but I direct one of the pain management centers. My two questions. First one is on, I was intrigued by the comment about pilot projects for David Elton on things like VR and other non-pharma care for chronic pain. If you could elaborate on that, and also as a clinician, how do clinicians connect with insurers to potentially be part of those types of trials or pilot projects?
Well, if you have a card, I'll take your card afterwards, and we'll. Yeah, there's a number of pilots and a lot of great innovation going, much of it driven by employers. Employers are very interested in this topic, and they have the ability within their benefit designs and geography to execute some pilots. And the ones I'm most familiar with over the last 6 months, I led an executive development team that's focused on virtual reality embedded in pain clinics to help people with chronic pain. And there, look, I'm not a trialist. I'm a little bit uncharted territory here, but what we learned through those pilots with hundreds of patients with chronic pain over 6 months, deploying visual reality, biofeedback mechanisms in office and at home, is the technology is easy to use. The patients reported, and through the biometrics, we could see better control of pain, more improved function, very low cost. And so those are the types of experiments. Yoga were less in terms of pure form pilots like that, but virtual reality actively involved in pilot studies on deploying that technology to help people with their chronic pain. And that's run through clinics, it's run with employers, it's run through patient populations that we identify and introduce these technologies to and then follow over periods of time. So a number of activities, and again, happy to take your card and we can explore how to collaborate.
Thank you. The second question is on the dichotomy that's been mentioned on chronic pain patients and their comorbid psychological issues. Many times those are excluded in some of the trials. And I'm wondering, when you're looking at cost efficacy or insurance data, such as non-opioids and maybe antidepressants or other treatments that are reduced by some of the non-pharma treatments, which may have benefit in those non-pain areas, any thoughts on how trials can be better implemented, or how cost efficacy can be better evaluated looking at areas other than just pain and function outcomes?
That's a good question. Again, I'm not a trialist, but when we look at one of the, big data is interesting, and when we look at big data, we can isolate populations pretty quickly, and when we put all the propensity matching in place and understand timing of introduction of these therapies and follow patients for 1, 3, 5 years and look at total cost over 5 years based on frontline interventions, we convinced ourselves anyway. Well, let me make this more real. So this summer at the Society of Actuaries annual meeting, we presented our economic model on value of these therapies, and if we can increase frontline use of chiro or a PT from baseline 30% today to 50% in 2 years, the annual economic impact for our commercially insured book will be north of $200 million total episode cost, total cost of care savings, net of the increased spend on these non-pharma therapies. So we come at it more from an actuarial perspective in actuarial modeling, leveraging big data, and if we use more of this, in total, we'll save surgery, imaging, injection therapy, opiate costs. And, we've convinced ourselves and a number of stakeholders that this is pretty powerful. We're talking big numbers here with simple changes in coverage and practice, emphasizing these non-pharma therapies. So not a pure trial, but more an actuarial modeling. And the numbers are substantial. And those are the experiments we'll be running over the next 2 years, is to illustrate, as we make these changes, how does that materialize?
Thank you.
Thank you. I'm just going to mention there's 4 more questioners. We'll go over to Christine. We have about 10 minutes, so we'll make sure to give everyone a chance, but no one else will be able to ask the question this session. Go ahead, Christine.
Great. Thank you. Christine Gertz, CEO of the Spine Institute for Quality. I want to thank all of the speakers for your excellent presentations. Roger, I just wanted I had a question or a point of clarification on the slide where you listed the harms that were associated with non-pharmacological treatments. I noticed that you listed cervical manipulation as a cause of serious harms, and the implication was that was a finding from the trials that you you had reviewed, but I'm not aware of a single incidence of a serious adverse event related to cervical manipulation that's actually been found in a clinical trial. And I'm wondering if you could, there have been a number of epidemiological studies, including one conducted by your colleague on the right, or I guess on the left, on this issue that have found that there probably isn't a causal effect, and so I'm just wondering if you could clarify that comment or that part of your slide.
Yeah, so the slide itself wasn't trying to say that it's a common adverse event. Obviously, it's still a very rare adverse event, and it's not from RCTs. This is from our prior reviews on low back pain, where we did look at large epidemiologic studies to look at risk of adverse events, and they showed they found a few cases of serious neurological adverse events with cervical manipulation. But again, it wasn't to try to imply that this was a common or likely episode. And you're right, the RCTs typically don't show these events, but you need large-scale studies to evaluate these types of harms.
Thank you, Dave.
And I was going to say, and the large scale and the big epidemiological studies don't tend to show the same kinds of things with lumbar manipulation. That was the only point I was trying to make.
Okay, great. Thanks. Dave, would you mind just commenting on the findings from the study that you did on this?
So again, with the sort of the big data environment, we have the ability to look at it from two ways. Manipulation for neck pain, follow those patients for 1, 3, 5 years and look downstream on adverse events. What we looked at was often at CVA or cerebral vascular accident associated with So we started with a population that had CVAs, worked upstream from that and tried to understand what were the treatments that were delivered prior to a CVA. And we really didn't find any relationship with spinal manipulation. You're more likely to have a CVA for neck pain following treatment to a PCP than going to a chiro. So we just didn't find any relationship between manipulative therapy and for neck and downstream adverse events. And that was a big data exercise, but that was our finding.
Thank you.
Thank you. Go to the middle.
Hi, Beth Darnell, Stanford University. Thanks to all the speakers. And I think my main question is to Patricia. I was really intrigued by the data you presented on CBT, and I was curious how you determined receipt of CBT, as I sort of naively assumed that this was from billing codes, and we don't really distinguish in the psychological billing codes the type of treatment that's being delivered. So I was interested in how you distinguished who received CBT, and even more importantly, was there any attention to receipt of CBT for chronic pain versus general CBT, which are completely different beasts? Thank you.
Great. Again, to clarify, those tables of individual studies, those were randomized controlled trials where they actually applied cognitive behavioral therapy for pain, usually in a group setting. So we actually knew that was what it was and what it was for. And then the models that I showed you, those actually used, again, data points out of actual studies. Right now, there's 14 studies in there. I would like to, we theoretically could put all studies in there at some point to look. But again, those come out of studies. So there was no real need to identify through, like CPT codes or something.
Thanks. Ben Kligler, I'm the Director of Complementary Integrative Health for the VA and a family doc. And I'm going to be one of those annoying people who makes a comment, but I do have a question too. So the comment is, we are there already. VA is the largest federal health system, and we're covering the complementary integrative health approaches, the evidence-based approaches. And so there's no reason that other large health systems and other large insurers cannot move forward. There's enough evidence. So that's my comment. Not that it isn't crucial to all of us. We're all researchers. We love to talk about the evidence. The second thing I'm going to say is a little bit of a challenge, which is, and I don't want to offend any of my great colleagues at NCCIH or elsewhere who are going to continue to fund all the great research. But some of this data is never going to come out of clinical trials. Who is the combination of CBT and acupuncture and yoga best for? That's never going to come from a clinical trial. You can't ask enough questions at the same time. It's only going to come from big data and pragmatic examination. So the question is, for David, really, how do you get all the other payers to the table to get the big data to really start to answer those questions once we get over the next little hump of everybody's covering it? But how do we get them all together? I think if that could be an outcome of this meeting, that would be fabulous.
Well, that's another challenging question. What I would say is, and I've referenced it really briefly, and Rob and I work together in this environment, is the intent of our setting up Optum Labs is to bring together all the data that we have, as well as other data sources, tie it out in an environment and in a venue, in a setting where we can bring together stakeholders and academic medical centers and leading researchers into an environment where we provide access to data, we ask the questions of the data we want to ask, let the research be conducted independently by the academic partners at the labs to explore these questions. And the study I referenced very briefly was one example of that effort, where we've got a lot of data. It doesn't do anybody any good if we keep our arms around it. How do we create a venue where we can come together and figure out and gain insights from that data? And that's the intent of labs. And that was just one brief example of a study that we've done there. But we're looking at Alzheimer's and autism and OUD and cardiovascular and kidney, and so it's an exciting environment. There's enormous potential in mining big data in a structured way with all of us together asking the questions. How we bring all the payers together and that kind of, that's beyond certainly my scope. But we're in the game at Optum Labs as an example of the potential. So I'll leave it there. Thanks.
Last question.
Liza Goblat, Academic Collaborative for Integrative Health. 2 comments and then a question for all of you, I think, which is, first of all, I would agree with Ben, what he just said, and Eric, that many of us believe that the evidence is really already strongly there. And I think one of the biggest questions that many of us have been looking at now for 10 or 15 years is on the whole issue of reimbursement and who decides who gets reimbursed and how the healthcare dollars are divided up. And so I think that's something tomorrow I hope that the policy session will begin addressing. But often the non-pharmacological approaches to the treatment of pain or in general are frequently affiliated with what are often called the complementary and integrative healthcare professions that are not necessarily part of mainstream healthcare. So I think that ties into the whole policy issue as well and how the healthcare dollars get divided up, so to speak. And then having been president of a Chinese medicine college, single-use needles now have pretty much been mandatory since 1997. And so I think that's actually also important for our data. But the question I have, because I think it really complicates the whole situation, is frequently when people are in really difficult chronic pain, they will put together their whole team. And they'll be seeing multiple practitioners, and frequently their team that they've put together, those individuals are not necessarily talking to each other frequently and very rarely really working together as a team. So how do you even begin to study and approach that?
Thank you.
I just thought I'd end it on.
Yeah. A yes/no type of question.
Yeah, I mean, it is an issue. How to coordinate and structure care, I guess, is kind of what you're getting at a little bit. And it's hard to study. We need creative people to figure out, how do we, look at different models of care and different ways of coordinating. And there have been some studies, some of them done in the VA actually, of coordinated, care models that actually do work better than usual care. The problem, of course, is how do you implement these in practice? And I work in a health system where we don't have very coordinated care, and this is, I get, occasionally I'll get a progress note or whatever sent from a surgeon, but we rarely have the kind of degree of coordination that you would like to have with a, designated care coordinator or whatever, method you are to do that. And, I think that's the future. I mean, this is bundled care, and, those are the kinds of things that having those kinds of payment models would allow you to do. And we're kind of moving towards there, but it's been pretty slow so far. And again, it's not easy to study.
Just a quick comment. So from a reimbursement and network perspective, right, we probably have 110,000 Chiro, Acu, PTs in our contracted network. So we have pretty good, decent scale. But what's more fascinating, again, back to the big data illustrations, we use what are called natural network tools. So when you look at all these data, there are pockets of innovation that you can clearly see on what providers have relationships within a local community are working together in a tight and integrated way, and that's by no means standard practice. But there are pockets of innovation the data reveals around these natural networks where, a patient doesn't buy a network of 500 chiropractors. They buy a network of the one that they want to work with, and the one acupuncturist, and the one PCP, and the pain management doc. And when we see those coming together in an integrated way in the data, that's where some powerful things are happening. So we kind of come at it from a big data perspective, and it's out there and it's emerging. But from a pure foundational perspective, there's enormous networks of these providers participating in the delivery system, but too often as siloed on their own kind of practitioners.
Well, thank you. I think we're off to a fantastic start. 10:30, we will start promptly with Dr. Dennis Turk. So take a break and be ready to go right at 10:30. Thank you.